grande.
Hello,
Ragazzi,
Ragazzi,
bambini, bambini.
bambini.
How are you, my friends?
kids, and you?
Very good, very good, very good. Did you celebrate the Women Day?
Yes, at home.
So happy Women Day to all our female friends.
Yeah, exactly. Happy Women's Day to all my great colleagues, great dermatologists.
Yes. Yes. Constantino, did you celebrate the Women Day?
Absolutely.
Yes. Did you
Happy
do
Women's Day.
something nice for the ladies around you?
The lady.
Lady, just one.
One.
Okay.
Do you agree, my friends, that women is the predominant sex?
Of course, clearly,
Of course, for
Clearly.
sure.
no question about it.
They're
There is
definitely,
nothing to discuss
they're
about
definitely the
this.
better sex.
Yeah,
Take a man and a woman. A woman can breastfeed, cook, clean, and work at the same time. Men
yes,
Yeah,
are
and
single-minded creatures. We
they
work.
can do at least five things
Yes.
contemporary. Five, because two arms, two legs, and the mouth.
Yeah.
They can do all this.
Yeah.
yeah.
We
In
can
my
do
view,
half.
in
We
my
can do
view,
half.
we men are after a certain age, we are useless. I mean, we are not,
No,
we're
come
not
on.
Even
contributing
before a certain age.
anything. We're not contributing anything to this planet.
Yeah.
No,
I am the
of course.
luckiest woman in the world because I have three great dermatoscopists with me, and I am so happy to be with you. It's a great honor and pleasure for me.
Grande. Okay, but Emilio, would you like to? We have a question of the week. When you look at an inflammatory lesion, what do you trust most? Inflammoscopy is very helpful. My dermoscope and my experience, just my eyes. Coffee first, diagnosis later.
Coffee first. But cheers to all the women.
Cheers.
Cheers, cheers.
Cheers.
I was afraid you
Bene,
weren't
bene.
drinking, Emilio.
No, I am, and this time I'm drinking the same with you, I guess.
Gin tonic.
Bene, bene, bene. So you go for just for water, Emilio, right? Okay,
No.
my dermatoscope and my experience. Okay, wonderful. So we know that, but by the way, we have to greet all our friends connecting from all over the world. Emilio.
For example, Parma, Hungary, Netherlands, Turkey, Russia with love, Romania, Turkey again, Albania, Riga, Ukraine, Azerbaijan, Georgia, Monaco, Armenia, UK, Poland, Chicago,
Oh.
Sardinia, yeah, Argentina. For some reason,
Yeah.
always when I see Argentina, I'm very, very, very happy. I mean, probably I'm affected by the last World Congress of Dermoscopy in Argentina, where we a wonderful.
Yeah.
And she's Gabriela. Hi, Gabriela.
Spain, Beirut.
Nikechi from Nigeria.
There's somebody saying that Nisa is the best, which we all know, of course, but yeah,
We
just
agree.
mentioning. We agree, of course. Lima, Peru, Kosovo, South Africa, Serbia, Brazil, Libya, Canada,
Fantastic.
Nigeria.
But sorry, there's a guy called guy or girl, sorry about that. Michael Grammatopoulo. So definitely Greek in
Greek.
origin.
Of
But
course, Greeks are everywhere. Greeks in
where are
Italian.
you from, Michael? Please let us know.
Yeah. Oman also.
Fun.
Germany, of course.
Sweden with an
United
Italian
Kingdom.
heart.
Okay.
Doriana. Wonderful, wonderful, wonderful. So today we will have the beautiful Nisa talking about inflammoscopy continued. Please,
Continued,
Nisa,
yeah.
the stage is yours.
Can you see my screen, my dear friends?
Not yet.
Is it okay?
No.
No.
No? Okay. Let me try one more time.
With Debbie, we're giving exactly the same responses at the same time. Now it works.
Now
Yeah.
it works. Great. So let's go to the first slide.
Okay.
Jeppy, please let me know if I am out of my time because we
Yeah.
have a lot of
Okay.
cases
Yeah.
again,
Okay.
and I can
Okay.
stop anywhere. Okay.
Wonderful.
So let's start with the pruritic lesions on the legs. So we have two lesions, and with your naked eyes, can you diagnose these entities? For example, what do you think about the first one and the second one?
Prurigo nodularis and prurigo
Lichen planus.
nodularis.
Great.
Oh, lichen
So the
planus,
first
okay.
one is prurigo nodularis, the second one is lichen planus, right?
Ah, bravo,
Great.
Costantino.
Bravo. Let's see the dermatoscopy for the first one. Do you agree with the diagnosis? Is this a prurigo nodularis?
Yes.
Yes, exactly. Because we have white structures and white lines like starburst pattern in prurigo nodularis, and this is highly specific for this disease. So we have white radial lines, and this is a typical prurigo nodularis. So well done, Konstantinos.
Thank you.
And for the second one,
Beautiful.
do you agree with the diagnosis of lichen planus?
Yes.
Yes, of course, because we have Wickham stria here. These white lines are Wickham stria. So this is a typical lichen planus. And another photo for the lichen planus. And now, this is a case of Enzo. The patient is a 62-year-old man, and duration is for about 3 months, and there is significant pruritus. So what's your diagnosis here with your naked eye?
Lichen simplex chronic.
Lichen simplex. Okay. And let's go with the dermatoscopy. Do you agree? Is this a lichen simplex?
Well, it looks like a Grover, no?
Yeah, that Grover, something like that.
Yeah.
Looking like Derriere or Grover, but the structures are pigmented, right? In Derriere, we have white starburst structures and yellowish structures again. And this time, they look like Derriere or Grover, but they're all pigmented.
Okay.
So what can it be?
I will take the help of the audience, which says lichen amyloidosis.
Yes, that's great. The diagnosis here was lichen amyloidosis, and all these structures are very typical for lichen amyloidosis. This time we have these brown structures like stars, and this is typical for lichen amyloidosis. Great. Now let's continue with...
Yeah, first Costantino and then me.
Yeah, so one small observation. I saw this by Nichetti, right? Lichen amyloidosis. In darker skin individuals.
In darker skin types, yeah.
Because people do not have so many skin cancers, they are so proficient in inflammoscopy.
Yeah.
Amazing. They get a diagnosis like this.
Yes.
Whereas we have more typical presentations.
Nikic is really great in inflammoscopy, and she has very great cases, and sometimes she shared with me.
I have another comment. You know, since lichen amyloidosis is not amyloidosis, real systemic amyloidosis is something completely different. So this is an histopathologic entity in which they find this kind of substance.
Amyloid deposits, yeah.
Exactly. But in my view, this is only just a phenotype, histopathologic phenotype of a lichen simplex.
I agree.
Exactly. Because
it's the
amyloid
same
deposition is due to pruritus.
Exactly.
Exactly.
So
exactly that.
just remember that the 3,000 dermatologic entities we have in our literature. They are not 3,000 diseases. They are 3,000 phenotypes.
Manifestations.
Yeah.
So how many are
Yeah.
there? 1,000 or less?
I don't know, maybe 1,000. Yeah, maybe.
Probably
Okay.
1/3.
Yeah.
And Jeppy, in through lichen simplex chronicus, we have white structureless, we have dotted and globular vessels on a whitish background, and this is typical for lichen simplex chronicus. And in this case, there is no amyloid deposition, as you can see. There is no pigmented structures, so just simple lichen simplex chronicus. So we can diagnose every pruritic lesions on the legs with our dermatoscopes easily. And here is the summary of the findings: hypertrophic lichen planus, prurigo nodularis, lichen amyloidosis, and papular lichen simplex chronicus. So you can take a screenshot. And no, this time I think it's easy. Can you guess the diagnosis here? Is this a morphea or lichen sclerosis atrophicus?
Lichen sclerosis.
Which one?
And
why?
Lichen sclerosis.
Which makes you to consider lichen sclerosis here?
The white color, the sharp demarcation.
And what else? There's one more clue.
Follicular plaques.
Very strong clue.
Follicular plaques. Follicular plaques.
Perfect. We have these follicular plaques here because in morphea, we can also see these white and yellowish structureless background. But here, the follicular plaques is the greatest clue for the diagnosis. So this is a case of lichen sclerosis.
Yeah.
And now, we can see these follicular plaques much more clearly here, white structureless background and follicular plaques, typical case of lichen sclerosis atrophicus. Now, we will continue with morphea. In morphea, again, we have these yellow and white structureless, but there is no follicular plaque. Sometimes vessels accompany to the lesions. The borders are not very well defined in morphea. As Jeppy mentioned, in lichen sclerosis, there are much more well-defined borders, but here you can see the borders, they are not so clear. And now, I have a question to you. Which one is morphea? Which one is lichen sclerosis atrophicus? Konstantinos, do you have any guess? Or Jeppy?
So I have a train of thought. The one on the left was harder to diagnose because I can see the biopsy. The one on the right has no biopsy. So the one on the right is morphea, and the one on the left is lichen sclerosis and atrophicus.
Okay, let's go with dermatoscopy now.
Yeah.
Is it clear?
Yeah.
Yeah,
clear.
because we have these follicular plaques here, white and yellowish structureless background, but these follicular plaques are highly specific for lichen sclerosis. And in morphea, we have just yellow or whitish background, no follicular plaques.
Yes.
Super.
Wonderful.
And now, any guess?
Morphea, right?
Morphea?
Morphea, right?
And lichen sclerosis, the first. So, does dermatoscopy support our?
Yeah.
Because again, we have these follicular plaques. Yeah, there are follicular plaques, and there is no follicular plaque in the second one. So the first one is lichen sclerosis, and the second one is morphea. And now, is it easy for you?
Discoid lupus?
Discoid?
Yeah. This is a case of discoid lupus erythematosus because we have follicular plaques, white circles, and vessels, erythematous background, scales, and sometimes we have brown circles around the hair follicles in morphea, and we have almost all the typical findings of discoid lupus erythematosus here. This is a fair skin type patient, and here is the close-up, fair follicular white halo and the pigmentation. And this is a skin of color patient. This time, all the features are pigmented. The background is brownish. We have those scales. We have follicular plaques. Actually, there's no difference. Just the brown coloration is the different point of skin of color patients.
Yeah.
Sometimes when DLE is a solitary lesion and especially located on the nose, we have a great differential diagnosis, which is actinic keratosis, because the structures really look like the strawberry pattern of actinic keratosis. Here's a case of DLE. You can see the follicular plaques, erythematous background. They are just looking like a strawberry pattern. The main difference here is the vessels. We have a lot of serpentine and linear vessels around the hair follicles in discoid lupus erythematosus. In actinic keratosis, we don't observe these sort of vessels in the lesions. So this is the main differential diagnosis when the lesions are located on the nose. Now, I will have a question to you. Is this a DLE or actinic keratosis? This is a solitary lesion.
DLE.
And this is located on the nose. What do you think it is? Actinic keratosis or discoid lupus erythematosus?
DLE.
Yes, this is a discoid lupus erythematosus because of the vessels. And here is the close-up of the vessels. We have a lot of serpentine and linear vessels around the hair follicles.
And maybe Nizaifa can comment. Another thing that we see in discoid lupus is this, which is perfectly shown in this image, an orange focally orange areas, which are very, very, very reasonable because we have a lymphocytic infiltration in discoid lupus, so it's reasonable to see from time to time orange color, which is not so well described in the literature, but it's true.
Yes. But can I add another differential? The localized rosacea is very, very, especially in this image, rosacea can also be a very confounding factor.
So
wonderful.
And here's the difference of early lesions and late lesions of discoid lupus erythematosus. And this is a really very good paper and published by Emilios and his friends. And here you can see in late lesions, we have telangiectasia, pigmentation, and white areas, which is the result of sclerosis. And here's
I was a very young guy when I published this paper.
Yeah, but it's a great paper, Emilios. I love reading that paper.
Yeah, it's a great paper.
And you are still young. Don't worry.
This Lalas guy has done a couple of nice publications. Couple.
Yeah. And here we have a late phase of discoid lupus erythematosus with white structureless background.
Yeah.
And this is a combination of late and active phase. You can see the active phase at the periphery and central, there's sclerosis here in the central part.
Yeah.
And now, orange and yellow color. This is a case. What's your clinical impression here?
Tuberculosis. Tuberculosis.
Tuberculosis, yes. Great differential. And what else?
Sarcoidosis.
Sarcoidosis. Okay. And now what do you think it is?
Same stuff. Yeah.
Same stuff, because it's generally impossible to differentiate. This case was a sarcoidosis. We have just orange background and focused serpentine and branch vessels, and there's no follicular plaque. And so we can differentiate leishmaniasis and discoid lupus erythematosus here because of the absence of follicular plaques. So this was a case of sarcoidosis. And here are more photos. And now, what is this?
Orange.
Again.
Orange and
in
focused vessels.
Yeah.
So this is sarcoidosis. Great. And now, what's your diagnosis?
Necrobiosis. But
Yes, perfect. This is a case of necrobiosis, lipodica, because we have these yellow and orange central part and a lot of branched and serpentine focused vessels at the periphery, and some of them are coming to the center. So this is a nice case of necrobiosis.
But in necrobiosis, I think that if you go back, Nisa, I think that the vessels are more in focus than in any other entity that I can imagine. I
Yeah,
mean, they
maybe
are
this is due to
super
atrophy.
in focus, super in focus.
Yes.
They are just
Yeah, because
jumping out of the
there is
skin.
atrophy.
Yeah.
Yeah.
Yeah, because of the
Yeah.
other. Yeah.
The main question is, what do you do with it?
Nothing.
Nothing.
Yeah.
Konstantinos, come on, don't talk about it.
Topical steroids, topical retinoids.
Yeah.
Okay, and I think this is easy because with
Well,
dermatoscopy, it's much more easier. What do you think it is?
okay.
We have
It is granulomatous rosacea,
Rosacea
Yeah.
or disseminated lupus fasciae.
which is the same.
Yeah.
Not the
We
same.
have
It's not the
Which is
same.
the
they were exactly the same entities, and we have also here some demodex tails, so we can conclude that this is a case of granulomatous rosacea. We have orange structureless, and we have vessels, which is a very typical finding of granulomatous
But
rosacea.
my friends, may I tell you something? I mean, a couple of times when we're discussing these cases, I told you that I consider granulomatous rosacea or disseminated lupus fasciae as the most difficult to treat entity because I had a few patients that I could not help them, but now I am so happy to share with you that in one of them at least, I was successful from a treatment point of view with high dosage of isotretinoin, but not
Yeah, it's very
Isotretinoin.
effective.
but
Yeah.
high dosage, not
What
not
do you mean with high dosage? I think it's 30 or 40 milligram is enough.
40 milligram. Yeah.
Yeah.
Yeah, high dosage because we usually use low dosage, like 10 to 20
10 to
milligrams in
20.
acne. Yeah.
Yeah, 30 or 40 is really great. And
Which
now,
of course, I'm not so sure if it was because of the drug or because, I mean, at some point this entity,
I
resolves
think
by
it's
itself.
no, but I think it's reasonable. Isotretinoin for heavy rosacea is great. So
yeah, maybe when it is due to these demodex and isotretinoin is effective on these parasites.
But generally speaking, I mean, when I have a patient with this, I always communicate with the patient that it's a difficult to treat thing. It's not a thing that it's not that we will do something today and
yeah,
tomorrow he's gonna be or
yeah,
she is gonna be
yeah,
okay. It's gonna
yeah,
be, I mean, persistent, probably resisting to the treatment and long-standing and so on. It's
yeah,
one of the most difficult to treat things for me. I mean, in
Yeah,
dermatology.
exactly.
yeah.
I
Now,
agree.
I think this is quite challenging case. What's your clinical impression here? But with
Lupus,
dermatoscopy, you
Lupus,
lupus
all
pernio, lupus
Lupus
pernio.
pernio.
Hernius
lupus hernia.
sarcoidosis, lupus
Yeah.
vulgaris, yeah.
So now
Rosacea
what do you
also.
think it is?
Again,
Oh,
granulomatous,
leishmania.
leishman.
Leishmania, great, because we have a lot of
Mm,
these yellow, in
yeah,
metaphoric language, teardrops, but actually there are follicular plaques and orange structureless background and some sort of vessels. This was a case of leishmaniasis.
Nice.
Because if this was a sarcoidosis, we will not expect these follicular plaques, right?
yeah,
So this is not a discoid lupus erythematosus because this
yeah,
orange coloration is too much for DLE. So this cannot be a lupus vulgaris because it has almost the same findings with sarcoidosis. So with the help of these yellow teardrops or yellow follicular plaques, we can easily say that this is a case of leishmaniasis, which it is.
yeah. Beautiful.
Let me ask you something. I mean, Nisa and JP mainly because Konstantinos, I guess that you also, as me, you don't see many cases of leishmaniosis.
Yes.
So, what do you do to treat them?
Okay.
And what do you expect from the
Well, glucantim is the
Glucantim.
official treatment.
Yeah.
But very often we just watch and wait. Sometimes we use Sporanox,
Itraconazole.
itraconazole,
Itraconazole. And sometimes cryotherapy is
yeah,
also effective, but
yeah.
glucantim is the best option, I think,
The problem is
intralesional.
that it's hard to find. Glucantim, it's hard to find.
And what do you expect that it's gonna resolve in a couple of couple of months?
Yeah,
After
the result is amazing. After 1 month of injection, they are all gone. But if you don't treat, there will be a scar tissue here. So we have to treat this.
Yeah.
Yeah.
I have seen.
So this is another case of leishmaniasis, almost the same features, orange background, and these follicular plaques and vessels.
Here, I would have done a differential with lymphoma.
Yes.
Yeah.
B-cell.
In this
B
case,
lymphoma. B lymphoma.
yeah.
Case,
Lymphoma is, it's a great differential here. Or pseudo lymphoma, reactive lymphoid hyperplasia. The patient is a young patient. He is 15 years old, and he was coming from endemic part of Turkey, southeast part of Turkey. That's why we consider here leishmaniasis, and biopsy also showed that it was a case of leishmaniasis. And now this is a, I think, challenging case for most of us. What do you think it is? This is on the tip of the nose.
It's the nodule,
There's a
right?
nodule here, looking like, again, a B-cell lymphoma. Yes,
Pseudo
could be.
lymphoma.
Or reactive lymphoid hyperplasia. Yes, could be. But any of them. So what's the diagnosis here?
Nodular sarcoidosis.
Yeah, it's a reasonable one, which I also consider. But diagnosis is a surprise to me because it was granuloma faciale.
Wow.
Very interesting, isn't it?
Very much, because usually granuloma faciale is relatively flat. So it's like not a nodule. I mean,
and
this is more in favor of
this is much more granuloma faciale.
This is granuloma.
Yeah. And here we have orange background again and unfocused vessels. And there is no follicular plaques here, but we can see follicular plaques in granuloma faciale. So this is another case of granuloma faciale in a skin of color patient. Just recognize the orange color is not very typical with the previous case, but still we have these orange color, and there are some follicular plaques, sparse follicular plaques around the lesion, and some unfocused vessels here, and some white lines. And here is a close-up. There are a lot of vessels here.
Yeah. Oh.
Another granulomatous disease. What do you think it is?
Wow.
Any guess?
These are the cases which I consider the most antipathic ones, because you have a rash which is clear cut and you remain like this and you say, what's that?
So we have a lot of orange papules.
Yeah.
And dermatoscopy also orange. And the vessels are unfocused, not very focused vessels.
Granuloma
eruptive papilla, how it's called.
Exactly. This is a case of disseminated granuloma ulnare. The main difference from sarcoidosis here is we have orange background, but the vessels are not very well focused as we see in sarcoidosis. This is another case of granuloma ulnare. This time,
this looks like a meth.
Or pityriasis rubra
orange.
PRP, exactly.
PRP.
LPLP?
PRP.
Pityriasis rubra pilaris.
Pityriasis rubra pilaris. Yeah, okay. But they were all papular lesions, but you're right. We can also consider pityriasis rubropilaris here. But this is another case of
therapy. What you did for these cases?
Yeah, in these cases, we have we treated the patient with systemic steroid, and the response was very good in both of the cases. But I generally give isotretinoin in combination with phototherapy.
Yeah.
Methotrexate also, of course.
Methotrexate, yeah.
I'm sorry, let me just explain what I did here. It's when Zepi asked what do you do with that, Emilius will get it and all the Greek.
Yeah, I get it.
So when you have nothing to do, what do? You cross them. It's like do the cross so that they get better.
Okay.
And this is easy.
Necrobiosis.
Yeah, because we have focused vessels. Perfect. And this is a case of Enzo again, and annular elastolytic giant cell granuloma, which is not a very frequent entity. But according to Enzo, the main difference between necrobiosis lipodica is the orange part is at the periphery, and we have serpentine and branch vessels starting from the periphery of the lesion and coming to the center of the lesion. He said that this is the main difference for these entities.
Great.
Let me tell you.
For example, there are two cases.
Never heard of that entity.
And for example, for the first one, if we go back, we have these serpentine and reticular vessels, and there are orange part is at the periphery, and the vessels are starting from the periphery and coming to the center. And in necrobiosis, these vessels are all at the center of the lesion, and this is the main difference.
Let me just tell you a comment which says Nisa is the best with capital letters and the most beautiful. And I agree. And I agree with Tamerlan.
But go back for a moment. Go back for a moment, Nisa.
Yeah.
Okay. Annular.
Elastolytic giant cell granuloma.
Yeah. Okay.
AEGC. Annular elastolytic giant cell granuloma.
Now, I have a question again. Because this is a very recent case that we examined last week, and this is the scalp of the patient. What do you think it is? Any guess?
Could be anything. Could be
LPP. LPP.
Yeah, like implanopilaris, folliculitis decalvans, but yeah, we have to see.
The lesions were involving the scalp, and there were some on the back of the patient, and the coloration was orange. And here's a dermatoscopy. We have a lot of follicular plaques around the hairs. The background is orange.
Yeah.
And here is another close-up.
Wow.
So, and this is UV dermatoscopy.
This could be mycosis fungoides follicular. Follicular mycosis fungoides.
Yeah, great differential. Yeah, great differential. And here's the back of the patient.
Breast metastasis.
Actually, in UV dermatoscopy, there is no Cutibacterium activity, so we can understand that this entity will go to alopecia, and here you can see there's an alopecia as well. Probably scatricial alopecia will develop. And histopathology was very interesting because it was sarcoidosis. I have never seen a scalp sarcoidosis previously, but in the textbooks, it's written that when it involves the scalp, it will result with scatricial alopecia. So maybe these follicular plaques, just like lichen planopilaris, will end with scapular alopecia. So do you have any experience with sarcoidosis involving the scalp
No.
No.
with these follicular plaques?
Never, never.
Never. Me as well. But really, it's looking like a lichen planopilaris.
Yeah, it looks like an LPP.
But the background is orange.
Dermatoscopically, no. Dermatoscopically, no.
Yeah.
It's not like an. But Nisa, let me ask you: how do you think that the blue light helps you, or you don't think that it helps you?
UV dermatoscopy.
Yeah.
With UV dermatoscopy, when the alopecia is superficial, you never observe Cutibacterium acnes activity because it's really very diffuse in the scalp in all patients, healthy patients. But when it is lost, we understand that the alopecia will be superficial. You see, but there is no pink activity in the scalp.
Okay.
Yeah.
Nisa.
Wonderful,
So-
Nisa.
Nisa,
Okay.
honestly, this has been amazing. I don't
Thank
like
you.
inflammoscopy so much, but with all the cases, the way you did it, like with the questions and everything, I was fascinated. I
Maybe,
was participating.
maybe let's go with this last case, this one.
Okay, this is the last case. In the later episodes, we can go with pigmented structures, and this is my slide, last slide. So what's your diagnosis here?
It's the Calvans. The Calvans.
For me, the Calvins as well.
Yeah, there's a superficial alopecia. So I think we all need dermatoscopy here. With dermatoscopy, now it's easy because it's a case of typical case of discoid lupus erythematosus. We have a lot of follicular plaques, background is erythematous. And now that's here is a close-up. And with UV dermatoscopy, no Cutibacterium, as you can see. So this is another case of superficial alopecia with follicular plaques, erythematous background, and typical case of discoid lupus erythematosus.
Nice.
Thank you.
Brava, Nisa.
Very nice. Very nice. Wonderful.
Wonderful, 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 wonderful.
Thank you.
Can I share my
Thank you.
screen for just 1 second?
Yeah, of course.
Because I found the case with severe rosacea that this is 1 month. Retinoids and original ivermectin. Look at the difference.
Yeah,
It's amazing. I love it.
yeah. What did you do?
Isotretinoin, 30
Okay.
milligrams, plus original ivermectin.
Okay. Great, 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 great. Wonder Woman, Gabriella is saying. There are no questions for the moment. No questions.
Why did you, Jamie, why did you say to Lisa to stop? I mean, we have still time for 5 more minutes at least.
Yeah, well, it's 7:40.
Yeah.
So I thought we had some questions, but it seems there is no question.
Unless Sebastiana wants to show us something or not.
Yeah, maybe.
Maybe Sebi wants to show us something.
Sebi
Yeah.
has been very quiet today.
Sebi is really, I mean, where is Sebi? Sebi did not show up.
Well, Sebi is in love. That's why he's.
Absolutely.
Okay.
I can tell without even knowing. He's in love.
Show Sebi.
Sebi, go. Go. Wonderful. This was Giovanni.
I did love
Yes,
Giovanni's face
with 80 scalp.
video with a hairy skull. Yeah, I mean, we should invite Giovanni in one
Yeah,
episode to speak to
yeah.
us about the sun protection effects of these wonderful sunscreens. Yeah.
Fantastic, fantastic. Okay, okay. So this,
Sansimed is not available in the USA, says Joanna.
Really?
okay.
But what do you have in terms of if Joanna can write to us? Do they have Actinica? Do they have the Isdin, how it's called? I don't remember.
Okay, ragazzi, ragazzi. So maybe I'm going to show you um,
Daria.
what Daria was sharing with us, as usually, impressive, good quality, good quality images, which is unbelievable. Can you see the screen?
Yes?
We are all
Okay.
curious.
Yes. Look at this. This is the forearm. Of course, we can
Lichen?
guess. Yes, we can
Lichen
guess that this
planus.
is the lichen planus
Lichen, yeah.
covering a tattoo. Yeah, and look how beautiful this
Amazing.
lichen planus. Unbelievable.
Super.
This is both polarized,
Amazing.
non-polarized, and lichen planus and tattoo. And the magic of UV and sub UV is the fact that tattoo disappears in UV mode. You see, more or less, you see, especially
Yeah,
here,
it's sub-UV.
tattoo disappears in sub UV mode. Yeah, which is fun.
Right.
And case number two, so differential, psoriasis,
Eczema,
eczema.
Eczema,
eczema,
Okay, what else?
tinea,
Tinea,
tinea manu,
but
yeah,
symmetrical.
symmetrical, it's difficult anyway. Beautiful spongiosis,
eczema.
though eczema. And this is what's going on, spongiosis in sub UV.
Spongios.
It's very clear, very
Very clear.
enhanced in some way. Case number three, psoriasis monitoring during biologic therapy. So this patient got a IL-17 inhibitor.
What is netakinema, by the way?
I never
Never
heard
heard
about
of
it.
it.
I
I
think it's
never
a
heard of
Russian
the
name.
Russian.
I've never heard about it. Yeah.
Yeah. So this is baseline before treatment, and you can see the beautiful dotted vessels of psoriasis.
Oh,
Beautiful
amazing.
video showing
Mhm.
beautiful dotted vessels. And then this is just 8 days after the second injection,
Second injection.
starting therapy. And here you can see that the vessels are completely different. You see now linear vessels, um, let's say
But why do they change?
much more, yeah.
Because you lose the spongiosis, I guess, and you look at them differently.
Mm,
So
mm.
the
Yeah.
Maybe the epidermis is not very acanthotic right now. Popular
So yeah,
dermis is
the
flattened,
yes,
and
epidermis not work too much
so
like this. Yeah.
the
And,
vessels are not tortuous anymore. So they're
yeah.
linear.
Wonderful, wonderful. Thank you, Daria.
Great cases.
Perfecto.
by the way, netakimab, brand name Efleira, is a Russian-developed humanized monoclonal antibody that acts on as an IL-17 inhibitor.
Okay, okay. Wonderful.
But
Emilio,
but now
yeah.
that I was looking at the cases of eczema, I, I cannot believe how much successful was the description of yellow scales in dermatitis. It's just
Mm, mm,
really
mhm.
super good,
Yeah, yeah.
super
Helpful.
good, super helpful. Yeah.
Yeah,
I
yeah,
remember, I mean, 10 years ago when we first were discussing about it, it's
yeah.
really nice. Yeah.
Wonderful. Okay, what
Okay.
Penelope prepared for us?
Chin asks, I would love to know from Daria which dermatoscope and camera she uses. Which is,
Yes, me too. Me too.
yeah.
Casio for sub
No,
UV
it's not
and
Casio.
DL5.
It's not Casio. Definitely.
Sub UV is Casio.
Debbie,
Which dermatoscope unites diagnostic precision and fits into any pocket? The Delta One unites diagnostic precision and fits into any pocket.
that
Great.
is really a great dermatoscope, really a great one. But I have to suggest something. I see a comment in the chat by Shin saying that, as you know, I have quite a collection of dermatoscopes. My pictures are not so good as Daria's. I have about 30 different scopes now. So, Shin, my challenge to you is that for the next happy hour, I mean next week or whatever, after 2 weeks, if you like, you can show us examples of lesions captured with 30 different dermatoscopes, or if not 30, at least 10, let's say. And then it's going to be really interesting to discuss, I mean, about, so I'm sure you can do it. So
The
it's
very same lesion. The very same
the
lesion.
very same lesion, of course, the very same lesion. Yeah, 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 yeah. If you have
Yeah,
it, please share it
yeah,
with us because
she has a great collection. Exactly. We
The
will
patient,
love to see all those cases, Chin.
yeah, just a few examples are going to be illustrative in my view.
the patient should be very patient to capture 30 different modalities.
But for some reason, I'm sure that she has done it at least to some extent.
Yes,
So
I can easily do that. Yeah,
yeah,
Chin.
okay. So we are waiting
Right.
for this next weekend or the other episode. Whenever you're ready, send us something and we can discuss about this because it's really interesting. I mean, it's really
Chin is the queen of the
the
motoscopes.
queen of the microscopes. Yeah.
Exactly, that's true.
Wonderful, wonderful. Okay,
Okay.
ragazzi,
Come on.
can you imagine that maybe today we are able to close at 8 o'clock?
No, come on, something
No
is
way.
going to happen for sure, for sure. Let's see Penelope. Let's see Penelope. Do you see my screen? Yes.
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 Okay. Case number one, 50-year-old. Yeah.
Rated sensitive plaque.
Sensitive. Of recent appearance,
But
on the
where is
scalp.
that? Is it the chin?
Scalp.
Oh,
But
oh, the patient is
something
like,
strange on the hairs of the scalp, eh?
yeah.
Okay, good. What?
Orange.
Granulomas.
Orange.
Ah,
Orange.
Orange.
oh, there's
Orange.
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 So
Deep
now
Sarcoidosis.
orange.
it could be sarcoidosis. Yeah.
Sarcoidosis, exactly. After Nisa, sarcoidosis.
Sarcoidosis or
Okay, so vascular pattern composed of linear serpentine vessels and so on.
So this is completely different.
Some
There's no
shiny
follicular
white
plaque
color,
here.
orange
I'm
color,
really
of course.
curious.
Lymphoma could be.
Lymphoma, come
Lymphoma?
on, come on. What kind?
Yeah,
Yeah, lymphoma.
lymphoma is much more reasonable. Lymphoma.
Lymphoma, guys,
Lymphoma.
impressive,
Wow.
impressive. Huh? Look at it. I mean, follicular center
Follicle
B-cell lymphoma,
center B-cell
but
lymphoma.
if you go back and see the clinical, it's impressive. I mean,
It's just
Yeah, but
nothing. I would have
it's
said
just
to the
flat.
patient, don't care about it, just
yeah,
I would
forget
have
it.
said exactly the same. Go home.
yeah.
Maybe some topical corticosteroid,
Yeah.
Really impressive case.
Well, but anyway, B-cell, primary B-cell lymphoma of follicular center type and marginal type as usual are usually very benign,
Yeah,
uh,
yeah.
very very easy to treat.
So you say this because you want to excuse yourself for sending the patient home.
Sending the patient
So,
home,
I mean,
exactly.
even if you go home, it's
Yes, yes,
still
yes,
okay. Still okay. Nothing bad
exactly,
is gonna happen.
exactly.
Cortisol
Okay.
will do that.
Very good. Case number two, 76, men, fluid prevented
The
lesion.
chest.
Okay, on the chest. Ooh, very
LPLK.
LPLK-like.
So we
LPLK.
decided that this lesion must not be biopsied
Yes,
anymore.
exactly. So
Yeah, exactly.
After last week, huh?
Yeah, okay.
Yeah. It's
Hopefully there are no surprises here.
But JP, we have
no surprise.
somehow to of course we made it public because we are in public in the happy hour, but
Yeah,
we have to write it somewhere that
somewhere. Yeah.
So for me, it is LPLK.
LPLK, yeah, LPLK, homogeneously distributed, yeah, yeah, clear cut
Clear
LPLK,
cut.
Thank you. Thank you.
yeah.
Thank you,
So,
Pascal.
so we have to
I
find a way to
relieved.
publish the notion that LPLKs do not necessarily need to be biopsied. Yeah.
Do not need to be biopsied. The end.
Yeah. Okay, 27 means benign.
Means benign. Yeah.
Yeah. Changing pigmented lesion, located on the lumbar lesion. Yeah.
Discomfort. Yeah.
Melanoma. This is
Annoying.
melanoma.
Annoying.
We know that we have to excise this lesion.
Annoying thing. Yeah,
Yeah.
annoying thing. Even in the age of 27,
Yeah.
that's annoying.
Yeah, I
Annoying.
don't like it.
Annoying. Okay. Okay, good, good. So dermoscopy here helps a lot to decide to decide. A typical reticular pattern, of course, some gray color inside to melanoma arising on a pre-existing nevus. Well, this is what I don't.
I don't believe that.
This is what I don't really. I mean, come on.
I don't buy
This
that.
is
Yeah.
This
Okay.
is the point.
this is all melanoma, I think,
This
not
is the issue
nevus.
problem. Maybe in the light brown part, this melanoma was less evident, and
Yes.
it was interpreted as a dysplastic nevus.
Yeah, yeah.
Exactly.
It's all melanoma, I think.
But
Yeah.
it's all melanoma. I couldn't
Yeah.
agree.
Mm-hmm.
We all agree. Perfect. Then scalp, multiple lesions,
Cylindromas.
Cylindroma, yeah.
3 inflammatory nodules,
Cylindroma
recent time on the scalp,
for recent time.
lymphoma-like in my view.
Yeah. Yeah.
Lymphoma-like.
Orange clods
Yeah.
separated by white lines, so that's very common in lymphoma.
Lymphoma, B-cell lymphoma.
Yeah, but three different lesions is strange for
But
lymphoma.
also very red. I would expect more orange. Cylindromas. I will go with cylindromas.
Yeah, you are super optimistic. You are in love, probably. That's why. Polymorphous vessels, of course. Yeah. Yeah, the white shiny lines and the salmon colored background. Yeah,
Oh,
Come on.
metastasis.
How
metastasis,
was the
metastasis,
patient?
metastasis,
How old
neuroectomy
is he?
of the pancreas
Hmm.
with metastatic involvement.
Yeah.
Yeah, I was
Was he 27 years old or the previous case?
no, this was 50 something.
Yeah.
Something.
Sebastiano, where are you, Sebastiano? Finally, Sebastiano showed up. I mean,
Eccoci.
hello, Sebastiano.
Eccola.
Hello.
Hello,
How are you?
I'm
Sebastiano,
fine.
Sebastiano is even not showing up at the clinic anymore. You know, he is so much in love that he doesn't care about
He's
dermatology
also in
anymore.
love. He's
Yeah.
also in love. Ah.
His
Yes.
priorities change.
Yeah, but it's a nice change of priority.
You
Yeah.
see, Sebastiano Love is just saying hi to us. Show up again. Show up again. Show up again. Hello.
Oh,
Oh
hi.
my God.
Yeah.
Sebastiano became so much more beautiful now.
Name.
Hai capito?
What's your name?
Oh my God.
Okay.
Nancy.
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 Nancy, we love you.
Is
Nancy,
he a
Nancy.
dermatologist?
Nancy, what?
Sebastiano.
I mean, Sunday
No.
evening, could you ever imagine something better to do than the dermoscopy IVR? Nancy?
I'm sure she can imagine much better things to do.
Okay, 70-year-old palpable lesion,
Okay, that's nothing. What?
No, it's a
like
Lichen planus.
Leopiris
Leopiris
like
like
Lichen
keratosis.
keratosis.
planus.
Leopiris like keratosis.
Leopiris like
There are
keratosis.
multiple.
Leopiris like
Multiple.
keratosis.
Sebby, do you agree that it's nothing
Yeah,
Lichen planus.
of
LPLK?
course.
Nancy, do you agree?
Of course.
She said yes.
She said yes. Okay, perfect. What's your diagnosis then? Yeah. Gray granules. Yeah, okay.
I think that
Yellow.
yellow or
Yeah. Okay. Okay.
Wonderful.
LPLK, which stands for Leopiris like
keratosis.
Leopiris like
Leopiris
keratosis
like
must
keratosis.
not be biopsied anymore. It's a
Not be
complete
biopsied anymore.
benign lesion, as the name indicates.
Yeah. Yeah. Do you want to retract your publication that you did many years ago,
Yes,
saying that,
let's
yeah,
do a retraction.
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 I retract.
We're gonna change the name.
Perfetto, perfetto. Bene, 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 bene. Allora, ragazzi,
I'm sorry. Look at the smile at Sebi's face. Sebi, we're so happy for you.
Debbie and
okay.
Nancy.
Allora, there is a question: how you differentiate from T-cell lymphoma folliculotropic, but we don't know which is the lesion we like to differ. Previous on the scalp lesion.
The nodular one.
The nodular
I think
one.
no. I think the flat one,
No, I think
the
they're
invisible B-cell lymphoma.
no, I think they're referring to Pascal's cases. No way to differentiate, just biopsy.
Yeah, yeah, clearly.
I think clinical impression is important.
The flat lesion on the scalp. The flat lesion on the scalp that you showed, Nisa, I suppose. No?
And I think it was Pascal's case, the flat one.
Pascal.
And you said that it's not important. They don't progress. They are not aggressive.
Yeah, exactly. Yeah. Yeah, but you know. Okay, guys, are you ready for Kahoot?
Absolutely.
Yes.
Yes, let's go. Let's go. Let's go. Okay, no, because I forgot to share sound, and sound is important.
It is of critical importance.
critically important. Loading. Okay. Classic mode start. Okay, well, we have 150 we start. That K like Sebi. Dallas te quiero.
Dallas te
Amore.
quiero, che bello.
Creative nicknames.
150. Okay, let's go. Oop. Nail. Nail. A nail.
Yes.
A nice
Okay.
nail. That's the clinical.
Ok.
That is dermoscopy.
Ah,
But
bellissimo.
there is also something more. The
Free
free
edge.
edge. Free edge.
Yeah, beautiful.
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 Beautiful. I mean,
Very beautiful.
does this create you any kind of feelings?
Very good
Yes.
feeling.
Good
Very
feeling.
Oh, yeah.
Yeah, feelings. Feelings are nice. And this is finally a glomangioma. Onicopapilloma, onicopatricoma, or onicomaporoma.
What of the what?
I think everyone will vote for onychomaticoma, but it's the glomangioma.
Yes.
Onicomatricoma. Onicomatricoma. Very good. And we have Mustafa at the first place. Enzo, which I guess is not Enzo.
Yes.
And
Not our
LPLK biopsier.
Biopsier.
Not
So
easy.
the one
Good love.
who is still resisting in our new trend to not biopsy LPLKs is in place number three, which brings us in the second case. That's the clinical. That is dermoscopy. Oh my God, why is it so small? I don't know.
Ah,
Oh, sorry.
I think the diagnosis is still feasible.
You think so?
Yeah.
Yes.
yeah.
Okay. What do you think it is? Seborrheic keratosis.
Of course, we needed a little bit more magnification.
Yeah, you need a little bit more. I mean, the magnification to see the spikes. Yeah?
The spikes.
The spikes. Yeah? The what we discussed about the previous.
Yeah.
Hedgehog sign.
Eh?
The hedgehog.
Yeah. Yeah, the hedgehog sign. Seborrheic keratosis is a difficult one, very difficult one. I don't know if we can. First of all, did you feel that this is seborrheic keratosis? or not?
Yes.
Well,
Yes,
there was
yes.
a clear differential diagnosis between melanoma and
Yeah,
SEPK.
of course. But did you feel it was a SEPK?
Clinically.
No, I would have
Yes.
voted for melanoma.
I
From
thought
this
it was
distance, you can only say melanoma.
Yeah. But you, Nisa and Konstantinos, did you
I
feel
thought that this
for
is a
SEPK?
seborrheic keratosis because
But
there's
Yeah.
some keratin cysts on the lower part, and I thought that it's going to regression with these gray tiny dots, which you say spikes. So
Yeah,
I thought
lots
that
of
this is
spikes.
LPLK or SEPK.
Yeah. But look at them here. I mean, they are, of course, the image is unfortunately very small, but I think that this is not something that we see in melanoma often.
No, but we cannot see anything, Emilio.
Really, eh?
Forget it. Yeah.
Okay, good. Bene, sorry for the
I
image.
have my glasses, Jeppy. These
Sorry,
glasses work.
I don't know why.
With these glasses, it works.
But of course, for Mustafa, and it was not a problem. Also for LPLK biopsy, it was not a problem. Let's go.
Triponema. I love
Triponema.
triponema. Come on, triponema is great.
Third case on the scalp. That's dermoscopy.
Okay.
What can I do more?
Yeah.
True or false? This is simply a solar lentigo.
Okay.
True. This is simply a solar lentigo with a clear cut network, reticular
Very
pattern
good reticular lines.
which is on the face absolutely in line of a solar lentigo. Very good. Which brings BCCoid
BCCoid
in the first place, followed by PG and happy woman in the third place. And case number 4, it's on the chin, Strange thing. Dermoscopy. Bello. Beautiful.
I don't know what it is, but it's so beautiful.
It's very beautiful.
I have no
And
idea.
diagnosis. Do you think it is a tinea nigra, lichen planus, porokeratosis, or granulomalare? Pam, 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 pam. Pam, pam, pam. Yeah, oh my God.
Lichen planus.
Lichen
Unbelievable.
Lichen
Yeah, but in retrospect, this is the most
reasonable
probable
thing
among
to
the
say.
among the 4. Yeah.
Yeah, porokeratosis that was voted by many people. I mean, why porokeratosis? There is no lamella.
Yeah.
At all.
It has a very nice, fine border. I can see why.
Tinea nigra is only affecting the feet.
Yeah, the feet. Yeah.
Feet or palms.
Yeah. Granuloma annulare.
So practically, it's probably a case of annular lichen planus with in the end phase where we have this.
Yeah.
Okay. What happened here is that nobody found it, so it remains in the first place, which brings us to case number 5, the last one. Let's go to the clinical. That is dermoscopy. Beautiful image.
Yes.
Oh,
nice.
Very nice.
Beautiful image. Yeah. And the question is, what is this? Do you think that this is seborrheic keratosis, pigmented Bowman's, BCC, or melanoma?
Well, clinically, it was completely suspicious.
But this is a beautiful seborrheic keratosis, of course, with multiple mainly coiled vessels. This is something that we have to clarify even better, that coiled and hairpin vessels coexist in keratinizing tumor, generally speaking. Because we usually described coiled vessels only in association with Bowens, which is not
The case.
Very good. So let's see what happened. Third place go to Double V. Bravis. Gaha. And the winner is Happy Woman.
Happy women.
Guys, Happy
Grande.
Woman is me.
Happy
It's you.
Woman is you.
Happy Woman is me.
That's
Today
a
is
problem.
Happy
Who was
Women's
the
Day.
second?
Gaha, Gaha,
Who?
Gaha.
Gaha. Okay, Gaha. Taha Dirim.
Bravo, Taha.
Second time.
Taha Dirim. Taha Dirim. Taha. Show up.
Grande.
Taha Dirim.
Taha is saying beaten by Nisa. That's okay. Taha.
That's okay.
Honestly, that's
Taha,
okay.
Taha, I promise myself I will never play anymore.
Hey,
But
Taha, of
this
course.
today
Hello.
was
I mean, we
entire
saw you
happy
again.
Hello again.
How are you?
Hi
Second
again.
time beaten by the Professor Benginisa again.
How do you feel that you are here on the stage again as a winner?
I'm so happy to be
So it
second
means
also.
we say that if you get the second time, you must get also the third time.
Yes.
He's really great. He very passionate on dermatoscopy. He's very hardworking,
Oh,
and
thank
we're
you.
so proud of him. Really,
But I mean,
bravo,
Thank
Taha.
you.
seriously,
Thank you.
I mean,
Teşekkürler hocam.
winning a competition among 200 people twice is not an easy thing. I mean,
No, not at all. Not
that's
at
a
all.
special talent, or
Thank
not?
you. Thank you, dear professors.
Taha,
not?
where are you located?
I'm on Turkey in Cappadocia, Nevşehir.
Cappadocia.
Cappadocia. Okay,
Yes.
Taha. Let me
He
tell
will
you
come.
now my complaint. My complaint is that Nisa, many years ago, promised
Many,
that
many
she will
times
bring us,
also.
she will
So
bring
That's
next
us
year,
wrong.
in Cappadocia. Yeah, and she
promise,
didn't do it. Yeah.
promise.
Maybe
Promise,
another
promise.
maybe other ideas about Dermoscopy Congress. Maybe in Cappadocia. It's just a wish.
Let's see.
Bene, ragazzi belli.
Thank you again.
Thank you, Taha. Thank you, my love. Thank you, my love.
Thank you, dear
My
professors.
loves. Baci.
Nancy. Say
Bravo,
before
Till
Taha.
next
talking about
Thank
Monday.
you.
you. Bye, Nancy. Bye.
Ciao.
Ciao, ciao.